The program is on carpal tunnel syndrome, which is a very common problem we see in our practice as a neurologist. And these patients also goes to other specialist clinic for a similar symptom like diabetic over diabetologist OP, and they reach the surgeon's clinic and neurosurgical clinic. So it's a very common problem. And I thought it's better take even though it looks very simple topic, it has a lot of we need a lot of scientific input to manage these patients appropriately. So I thank the chairpersons, Professor Dr. Vishwakumar and Dr. Vijay Anand. Professor Dr. Vishwakumar is well-known senior neurologist, and he has a lot of credentials. So he's very senior in the field of neurology. He's FRCP in Glasgow. He has got DSc honors, and he do a lot of social activities. And he's a very good clinician, well-reputed clinician in the field of neurology. I thank you very much, sir, for the presence to chair the session. And I thank Dr. Vijay Anand, Senior Consultant Neurologist at Meenakshi Mission Hospital at Madurai, to agree to chair this session on this carpal tunnel syndrome. There are three topics. I'll be talking briefly on carpal tunnel syndrome, the introduction, and Dr. Ati Ponnusamy, Senior Consultant Neurologist and Clinical Neurophysiologist at Manchester, UK. He's done his DM from Chennai, Madras Institute of Neurology. He done his MRCP, he's an FRCP London, FRCP Glasgow. He has done a certificate of completion of specialty training at the UK. And he's a very knowledgeable, very humble and knowledgeable neurologist and neurophysiologist. He'll be talking to us on neurophysiological approach to carpal tunnel syndrome. Dr. Ganapathy Krishnan is very senior in the field of plastic surgeon. I know him from the time of Apollo when I was with Apollo, and is a very efficient plastic surgeon, and he has done a lot of challenging patients for my own patients, and he has quite a lot of experience in plastic surgical field. And he's going to give us a talk on surgical approach to carpal tunnel syndrome, because most of the time we see clinically, we diagnose neurophysiologically, then we refer to the specialist for intervention, specific indication for that. And it is very important to know what is the exact advance happened in the field of surgical intervention. So this is a brief introduction about the today program, and we will finish it well in time, and we'll have question and answer session, which will be coordinated by the chairpersons. So I'll start my talk first.
Thank you, Dr. Pazhani.
Yes, sir.
Thank the South Indian Neurological Association Forum for the opportunity given to us to be the chairpersons, me and Vijay Anand. We have a blend of geriatrics and youth, and we'll have an eminent panel of specialists in their own field. Dr. Pazhani will give us an introduction to the pathophysiology clinical aspects of the carpal tunnel syndrome, and Dr. Ati Ponnusamy will take us through the electrophysiological studies, and then we'll have a surgical treatment of it outlined to us by Dr. Ganapathy Krishnan. Without much further ado, may I ask, I welcome my co-chair, Dr. Vijay Anand, and we'll answer the questions we may put in the chat box. We'll take up the questions all together at the end of the session, and may I now request Dr. Pazhani to present his paper. You do not need any introduction. Dr. Pazhani does not need any introduction to this audience or any audience in India and abroad. He's been conducting this webinar, and he is a fellow of the Royal Colleges of London, Edinburgh, Ireland, and Glasgow. He's got some very unique fellowships to the European Board of Neurology and European Neurology and the American Neurological Association. He's also got a law degree, and he is specialized in astrology and music also. Over to Dr. Pazhani, please.
Thanks for your blessing, sir. So can all of you see my slides? Can you see my slides?
Not yet.
Can you see my slides, sir?
No, not yet.
No,
okay.
Not yet, sir.
Then I have to open it. I'll do it.
May kindly request everyone to mute themselves so that and the video also if possible, so that we preserve the bandwidth. Yes, Dr. Pazhani.
Can you see my slides now, sir?
Now we can see it. Please go ahead.
I'll go to the presentation mode, sir. If you're not able to see the slides, kindly let me know so that I can correct it. Thank you very much. And I will be talking very briefly because there are important speakers going to talk on the important aspects of carpal tunnel syndrome. Just the basics of carpal tunnel syndrome. Carpal tunnel syndrome refers to the complex of symptoms and signs brought on by compression of the median nerve as it travels through the carpal tunnel. Commonly, the patients experience pain, paresthesia, and less commonly weakness in the median nerve distribution. Carpal tunnel syndrome is the most frequent compressive focal mononeuropathy seen in the clinical practice. And we see quite a lot of peripheral nerve problem, and carpal tunnel syndrome is the common compressive focal mononeuropathy what we see in the clinical practice. The carpal tunnel is formed by the transverse carpal ligament, flexor retinaculum superiorly with the carpal bones inferiorly. The median nerve accompanied the 9 flexor tendons of the forearm musculature pass through this tunnel. When compression of the median nerve occurs, ischemia and mechanical disruption of the nerve follow. The median nerve emerges from the brachial plexus in the upper arm with the contributions from the C6, C7, C8 and T1 nerve roots. Roots C6 and C7 supply the median sensory fibers that provide sensation to the thenar eminence and the first 3.5 digits of the hand. Roots C8 and T1 supply the motor fibers to the muscles of the forearm and hand that are innervated by the median nerve. The nerve roots that are destined to compress the median nerve travel in the upper, middle, and lower trunks of the brachial plexus. These fibers will then pass through the lateral and medial cords of the brachial plexus and combine to form the median nerve. So this is the basic anatomy of the median nerve. The further details, the other speakers will tell, the physiology and the surgical aspect. The median nerve has no branches in the upper arm. As a median nerve passes through the antecubital fossa region, it lies adjacent to the brachial artery on the medial side before passing more deeply within the forearm. In the upper portion of the forearm, the median nerve innervates 4 muscles: pronator teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. The median nerve then gives a peripheral nerve branch that forms the anterior interosseous nerve, which innervates the pronator quadratus muscle just proximal to the wrist. The anterior interosseous nerve also innervates the flexor pollicis longus muscle and medial edge of the flexor digitorum profundus 1 and 2 muscles. The median nerve proper runs parallel to the anterior interosseous nerve in the forearm. The region proximal to the wrist, the palmar cutaneous sensory branch of the median nerve, comes off to provide sensation to the lateral half of the palm. So it comes off before the wrist. Because the branch of the median nerve change involving the thenar eminence is not typically observed in the carpal tunnel syndrome. After coming to the carpal tunnel, the median nerve provides motor and sensory innervation to the hand. The muscles of the hand that are innervated with the median nerve are abductor pollicis brevis, superficial edge of the flexor pollicis brevis, the abundance pollicis, and the first and second lumbar.
We've lost you, Dr. Pazhani.
And sometimes the lumbricals can be still spared. So if you see the carpal tunnel syndrome, then normally that they can have edema in the carpal tunnel or inflammatory conditions. The nerve is compressed at the carpal tunnel with the hourglass-shaped deformity. Both proximal and distal, there is edema. At the site of constriction, there is a narrowing. Congenitally small anatomic space, mass lesions like cyst, neoplasm, or persistent medial artery can compress the median nerve at the carpal tunnel. The lowest carpal tunnel pressure there is a pressure in the carpal tunnel, normal, new or slightly flexed posture. So if you flex and certain kind of position, the pressure is low. But if you deviate the hand position from the flexed position, the pressure in the carpal tunnel increases. This is very important because some patients have a very small carpal tunnel syndrome is 2.2 to 5.4 per thousand for women, 1.1 to 3.3 per thousand for men. Studies done on pediatric population. There is an article in Pediatric Neurology in 2014. There is a report of 13 patients with carpal tunnel syndrome. Carpal tunnel syndrome is higher in obese women and lowest in thin and normal sized men. The female to male ratio is approximately 3:1. The risk factors are obesity, female gender, pregnancy, diabetes, rheumatoid arthritis, osteoarthritis of the hand, hypothyroidism, connective tissue diseases, pre-existing median mononeuropathy, genetic predisposition, aromatase inhibitor use. This drug used for inhibiting the estrogen in breast cancer. The main way it produces carpal tunnel syndrome is this aromatase inhibitor can increase the tendon thickness. That's why it compresses the medianum at the carpal tunnel. And workplace factors. If you take the genetic predisposition, there is limited data suggests some patients have genetic predisposition. A twin study found that up to one half of the liability in carpal tunnel syndrome in women was genetic. Bilateral carpal tunnel syndrome patients more likely to have a family history. Inherited anatomic variability in the size of the carpal tunnel, which I was telling before that some people can have a small carpal tunnel. Familial predisposition to other medical conditions like diabetes. Some unidentified predisposing factors. These are the reasons of genetic predisposition of carpal tunnel syndrome. So workplace factors are repetitive hand and wrist use, forceful hand and wrist use, work with vibrating tools, sustained wrist or palm pressure, prolonged wrist extension and flexion, use of hands in cold temperature. So this is the basic details I want to tell about carpal tunnel syndrome. The neurophysiological approach and surgical approach will be discussed by the next speakers. And thank you very much for listening to me. I have finished my talk, sir. Dr. Bishop Kumar, sir, I have finished my talk.
Shall I start my...
Thank you, Dr. Palni, for a very clear and very short, crisp introduction to the carpal tunnel syndrome. May I now go on to the study of the neurophysiological studies in the carpal tunnel, in the case of carpal tunnel syndrome. I request Dr. Adi to give his talk.
Thank you, sir. I'm just sharing the screen. Just a second. So all of us are able to see my screen and hear me properly?
Yes.
Thank you.
Yeah. Yes, Dr. Adi.
Yeah, so thank you for this opportunity. Thank you for inviting me, and thank you, chairpersons and colleagues. So for the next half an hour, I am just going to elaborate on an overview about neurophysiological approach to carpal tunnel syndrome. So the objective I want to cover are the follows. One, why we need to do neurophysiological tests in the first place in carpal tunnel syndrome. And then what are the current neurophysiological techniques we are using and the sequence we are applying. There are lots of discussion on it. I'm going to show a sequence I'm using. And then I just want to give some overview about the current guidelines and practice parameters on this. And then there are lots of grades of severity of neurophysiological severity grading in carpal tunnel syndrome. So I'm going to highlight on that and the usefulness in clinical practice. And I'm also going to touch upon a brief underpinning pathophysiological aspect of the neurophysiological findings we get. And then there are lots of literature emerging in the past 10 years or so on ultrasound diagnosis of carpal tunnel. Even though my talk is purely on neurophysiological aspect today, I just put 2 slides to give a overview, and then I suggest some future directions and some collaborative work in terms of research, if possible. So, first of all, why to perform clinical neurophysiological testing in carpal tunnel syndrome? So this testing helps to confirm the clinical diagnosis, and it helps to assess the functional severity of the median nerve lesion at the wrist, and they provide an objective baseline for future comparisons. And then these are helping us to exclude also the alternative diseases which can mimic carpal tunnel syndrome or coexist with the carpal tunnel syndrome. So as we all know, carpal tunnel syndrome is a clinical syndrome. Yeah. So any test we are doing are helpful in the confirmation of it. We can't say that just because a test is abnormal, there is no carpal tunnel syndrome. Okay. So that is the fundamental aspect of it. So what we are trying to achieve in diagnosing by these tests, neurophysiological tests, in a person clinically we suspect having a carpal tunnel syndrome. Yeah. So because we want to know whether there is an objective evidence for compression and slowing of the median nerve at wrist. Okay. So mainly the slowing aspect, because it's a functional aspect, it can be done only by the neurophysiological means. The structural compression and also other anatomical compression at this place can be given by imaging findings. Okay, so they are complementary to each other. We need to use it prudently to diagnose and get more evidence in the management of carpal tunnel syndrome. So nerve conduction studies provide a reliable measure to document median nerve neuropathy, entrapment neuropathy at wrist, and therefore it contributes to the diagnosis of carpal tunnel syndrome. And it is quite accepted that there is no single gold standard in the diagnosis of carpal tunnel syndrome because it's a clinical syndrome. So all our sensitivity and specificity in all this literature are based on some other modalities or clinical improvement after some intervention. So we need to interpret those findings with those kind of background. So how to diagnose it? So Dr. Pazhani has nicely mentioned about the full course and how it reaches here, but we want to confirm that there is a compression and slowing of the median nerve at the wrist by doing some electrophysiological testing. And also we have to prove that the proximal segment is normal and there is no other diseases affecting the proximal course of the median nerve as a confounder or coexisting factor, and also there is no other nerve or neurological structure in the peripheral nervous system in that patient. And also, as the nerve is surrounded by lots of tendons and joints and ligaments and all these things, so any inflammation of these structures can mimic carpal tunnel syndrome. So we want to be very clear about how much of the symptom is coming from the neurological compression and slowing of the nerve. So that is the crux of the understanding to apply neurophysiological testing. So this is the flow I follow because most of these work, myself and Dr. Pazhani are trained by Dr. Bland. Jeremy Bland is from King's College. So he has the very biggest database, even in those days. So I left King's 2006. In those time, it was 5,000 cases. Most of his initial publications are from 5,000 cases. But now he has about 35,000, 40,000 cases and replicating the same data. So we have a large body of evidence-based information gathered by these kind of studies. So we tend to follow the flow, but I'm not saying that this is the only flow, that various people are following various kinds of diagnostic flow. So we ideally, because we are in a cold country and the hand temperature is very important, and in any country this is hold true, and ideally it should be more than 32, but at least 30 degrees centigrade. Okay, so that will affect your latencies and velocities. So first we do a median digit 2 to wrist sensory conduction, and then ulnar digit 5 and wrist sensory conduction. You can do orthodromically and also antidromically. Most of the American literature, everything is antidromically. Okay, so they stimulate the wrist and record in the digit. The amplitudes will be very huge. So you can't compare the amplitude of the antidromic study with an orthodromic study. Yeah, so orthodromic study, the amplitudes are less than, much less than your antidromic studies. So why not do only the median now? Because we want the same patient as an internal control for lots of the other confounding factors like age, gender, temperature, body habitus, the job they do. So all these things we need to have a internal control, and we need to do one more nerve in the same hand to start off with the ulnar nerve, provided there is no clinical suspicion of ulnar neuropathy or polyneuropathy. So in that, if that is so, then in the sensitive parameters, you concentrate more radial nerve than ulnar nerve. But starting off, a good practice is doing a digit 2 and wrist in median and digit 5 to wrist in the ulnar. The distance is ideally it is 13 centimeter, but between 11 to 14 centimeter is okay. So all these values are ranges of whatever we do. So whatever parameter the following numbers I put it in that slide is based on assuming those distance measurement is between 11 and 14 centimeters. Okay, so if the distance is in the outlier, then we can't. You have to have a value from your local laboratories, or these can be very strictly followed. So provided these constraints, any peak latency difference. So then the question of onset latency, peak latency. When you compare the velocity, always compare using the velocity calculated by the onset latency. But all these research-based cutoff values using receiver operating characteristics in many studies are based on peak latencies, because onset latency, because of the stimulus artifact or some positive dip, we may not know where the onset latency exactly is. But the peak latency is very, very rather robust feature. And whether you do antidromically or orthodromically, the amplitude varies, but the latency, the peak latency doesn't vary much. So you can apply, extrapolate data from an antidromic study to an orthodromic study for the peak latency, but not the amplitude. Okay, and calculation of the velocity is always sorry. There is a message coming. I need to start the video, but I thought to conserve the wavelength, I didn't switch on the video. Is everything okay now? Am I okay to proceed?
Yeah, we're able to see this, but your slide is not moved.
Is it
now
moving
it's okay.
now?
Now it's okay.
Yeah. So the peak latency difference from median to ulnar of 0.4 millisecond or less, and it's normal, okay? And between 0.5 to 0.9, it's borderline delay. If it is delay, the median in that way, it is borderline delay. But if the patient has diabetes or polyneuropathy, even that could be due to those factors, not due to carpal tunnel syndrome. But if the median peak latency from digit 2 is 1 millisecond delay or 1 millisecond or more delayed when compared to the digit 5 peak latency, it's clearly abnormal. So you don't need any sensitivity test. You can go straight to the motor test. But if the peak latency difference between digit 2 and digit 5 is normal or in the borderline range, we need to go to the sensitive test. Okay, then what sensitive test we can do? So the slide moved, isn't it? Yeah. So
Yes, yes.
yeah. So the sensitive test, there are various sensitive tests, and depending upon people's preference and the way they are trained and the way they are comfortable with, they can mix and match. So at least 2 is better to do, but 1 is mandatory. So we normally do median and ulnar palm to wrist segment, the nerve action potential in an 8 centimeter across the carpal tunnel. So the peak latency difference of the median delayed more than 0.3 milliseconds from the ulnar is considered abnormal. And also we can do median ulnar comparison from digit 4. I put some pictures for it later on in a 14 centimeter segment, and median and radial comparison in the thumb in a 10 centimeter segment, and stimulating the ring finger and recording from the wrist in between median and ulnar recording site. And if you have a good double peak with the peak separated by more than 0.4 millisecond, you can say that the ring finger, median and ulnar fascicles are conducting in a different speed, and the later peak is from the ulnar nerve. So median is much slower than the ulnar. So you can get an impression like that, a double peak in the ring finger with the interpeak latency of more than 0.4 milliseconds. So there are lots of names for this: palm diff, ring diff, and thumb diff for the sensory tests. Okay, so once you finish those sensory tests, whether after the sensitive test or if it is clearly abnormal after the initial digit 2 and digit 5 comparison, you move to the motor studies. So in the motor studies, you do the median motor wrist and elbow to APB. So we are comparing the distal motor latency to APB. 4.5 is the usually in a segment of 7 centimeter distance. 4.5 is upper limit of the normal, but some labs have 4.2 as the normal. So 4.5 is good. And forearm motor conduction velocity should be normal. So the delay must be from the wrist down, not above. So the forearm motor conduction velocity should be 50 meters per second or more. We have to bear in mind that in severe CTS, even the forearm motor conduction velocity can dip down to 41 or 38 or 44 or something like that. It never goes in 20s or low 30s. So it's always more than 40, but less than 50, that kind of range. It can happen in a Wallerian degeneration in a severe CTS or severe conduction block. So those fascicles, motor fascicles, which are blocked completely, they are not including in the velocity calculation. So you drop out some axons which are not conducting. So you get those kind of caveats. If you want to really prove it, you have to do a terminal latency index and prove that the latency is less than 0.34. So this is proving the conduction slowing is distal, not a part of a diffuse demyelinating pathology in the median now. Okay, so if no compound muscle action potential at all over APB, then we can do a median to lumbrical and ulnar to interosseous comparison in the motor study and prove that it is really the delay is in the wrist and it's only the median and the ulnar is normal. So you have to prove a median mononeuropathy and which is entrapped and distally affected at the wrist. So these are the studies which help us to understand that or diagnose it. And if we don't have any CMAP over APB, then how to say that the forearm motor conduction velocity is normal in those cases? You can do those lumbrical and interosseous study. On the top of it, if you do an elbow stimulation in the median, record from pronator quadratus, and if that velocity is normal, then you can say that the problem is distally in the wrist, not further up. So these are the motor studies to choose from to prove carpal tunnel syndrome. And in selected cases, say there is a Colles fracture or another kind of distal radial fracture, and you want to prove the median entrapment is not across the fracture site, it's across the carpal tunnel, which is further distally down Then you can do inching studies, and the inching can be done for the sensory as well, either sensory or motor inching to prove the exact site of block. Okay, and then it's customary to do an ulnar motor studies to show that these are normal. EMG is only optional case scenarios. So if you have a low CMAP and you want to prove that it's indeed axonal, it's not due to distal motor block, then you can do a needle EMG of the APB. And otherwise, usually it's not necessary. Another occasion is if there is a non-localizable axonal median neuropathy, you are not able to localize on the wrist, and how to prove the median nerve pathology we are seeing is part of a plexus or high median nerve involvement in the forearm. You can do in those cases needle EMG of the APB, needle EMG of the pronator quadratus and FPL and flexor carpi radialis, and say that these muscles are all normal and only the problem is in the APB. Then you can see that this axonal median nerve pathology is at the wrist, not further proximally. Okay, and also EMG is helpful to rule out the root pathologies, mainly C6 and C7. In those cases, you can do flexor carpi radialis and triceps and extensor digitorum communis needle EMG to say that assess the myotomal EMG findings for the root. Okay. So all these things I mentioned are the crux of the neurophysiological findings or assessment. And these are well elucidated in American Academy of Neuromuscular Medicine, Electrodiagnostic Medicine. This monograph I follow is highly rated, and it's good, and most of us would have seen that. I just want to re-emphasize during our talk today, even though it is 10-year-old. So exactly what I have told in a slightly different way, they have found and they have put a flow chart and these are all highlighted as standard and guidelines and options. Standard is for everybody has to do it because 90% of these cases are done by the physiologists. They are not done by physicians. Only when these referrals come, we triage and then get only the complex cases, and then all of them goes to the physiologist in many countries, including UK. So when you give them, you have to get a standard for the whole nation or the state to compare. So and the professional societies, it must be something similar should happen in Indian Academy of Neurology or some societies there, but it's customary to have the standard and then guidelines depending upon the physician's understanding and options for research. And I think the standards are the median sensory, ulnar sensory, and the sensitive parameters, and the median distal motor latency. Those are the standards. Everything I told are guidelines or options. So this is how the median digit 2 to wrist and median ulnar digit 5 to wrist are done. Here in this one is antidromic. The stimulation is at the wrist, and the recording is in the fingers. Then you get a big amplitude. But you can, the customary way to do in many countries, which is validated in 1985 by Kerry Mill, is orthodromic. So orthodromic, you stimulate there and record in the wrist, and the amplitude. So you have to have a cutoff for the amplitude, which is very different, but latency is normal. Same values we use for antidromic and orthodromic, and same thing for digit 5. And this is the 8 centimeter, one of the sensitive tests I mentioned, form diff. And these are nerve action potentials. And across the wrist, either you stimulate there and record here or the other way around. Either way, you may get some motor. Even if you stimulate here, there'll be some retrograde fibers goes to palmaris tendon and muscles. You may get that positive dip, but you have to adjust your anode and cathode to get a nice onset without any positive dip to get the correct information, which is very useful. And also you can have antidromic median sensory study from the ring finger. And then, so when I explain orthodromically, you stimulate in the finger and record at the wrist, and then you stimulate the finger and record in the palm. And that distance between palm and the wrist should be 7 to 8 centimeter. If you do that, then you can subtract actually what is the velocity across the carpal tunnel, across the palm to wrist. Yeah. So if that is disproportionately slow when compared to this measurement, then you can localize the pathology across the wrist. The same thing can be done in the middle finger as well. And this is a ring finger wrist to median wrist to ring, and ulnar wrist to ring, and then take the difference of the peak latencies, which is anything more than 0.4 is abnormal. I mean, the delay should be in the median side. And this is the thumb diff. So the short segment, 10 centimeter, because all the values are standardized for those measurements. And median and ulnar motor, how we normally do a motor action potential amplitude, wrist to APB, wrist to ADM. And lumbrical and intraosseous comparison. The recording electrode is in the second interdigital space, and then you stimulate the median, and then you stimulate the ulnar, and in a 10 centimeter equidistance, and then look at the latency difference. Okay. And this paper also gives all the normative values I told. It's a good thing if you do this on a regular basis, or ask the technicians to do, familiarize with the values, and then put a guideline for your practice. So this is what you have to do, and this is my cutoff value, and this is what I'm saying is abnormal. And always compare that in the clinical picture. If anything doesn't fit in, then you have to do by yourself for a more extended study and examine the patient properly. And this practice parameter is also very good, American Academy. And so the physiologists started to do this test in 2005-6 onwards in UK. And because all those departments having various things, the society wanted to uniform or regularize the practice. So in 2012, the British Society of Clinical Neurophysiology and Association of Neuroscientists, which is a technician association, so they combined together in 2012. It's available in BSCN website, and there are some standards which is essentially what I told in words, really. So I don't want to browse too much on your time there. But if you're thinking about developing some standards and guidelines for the practice, and then change it to the local need, and the practicalities are different. Every department has its own intricacies. So but this gives a baseline and a rough idea about what is what needs to be done, and then you can set up your own protocols. So that is what we do. Now, quickly, in another 10 minutes, I talk about what does mean, and how it helps. So even though the sensitivity and specificity of all these things that it's already in the American Academy practice parameters, the specificity is very good. Everything is around 0.95 to 8. But the sensitivity, the palm diff and digit 2 to digit 5 sensitivity, those two tests are very high. And the rest of them are in the 70s. So palm diff and digit 2 and digit 5 comparison is very good sensitive test. And overall, we got this sensitivity of 85% and specificity is 95%. That means it's not 100% either. So that means you can have carpal tunnel syndrome with a normal neurophysiology. And that means normal neurophysiology doesn't exclude carpal tunnel syndrome, but it puts the grade, I come to the grade in a little while, to a grade not to send them to surgery or injections, only splinting and supportive care, and then repeat study after 6 months or 8 months. Okay. And you can have neurophysiologically evidence of carpal tunnel, median nerve neuropathy at wrist, but patient may not have any symptoms. So that means you don't diagnose carpal tunnel syndrome based on neurophysiology. So then in those places, we use the term median neuropathy at wrist, asymptomatic. That's it. For carpal tunnel syndrome, you should have the clinical symptoms and signs. And then your neurophysiological finding or ultrasound finding makes sense. Without that, everything is a test finding, but we are treating the patient. Okay? So, but in a patient complaining with those kind of symptoms, and if you have a clear idea what we are dealing with, there is no need to do any test. You diagnose carpal tunnel syndrome clinically and treat it accordingly. But before intervening, like more than injection, like a surgery, it's better always to prove it is, because all the procedures we are going to do is not 100% efficient either. So it works for only 85%. So two-fifths of the patient comes back to the clinic, and what to do? And there is no baseline study to compare with. Yeah. So then you end up in having whether it is really indeed the carpal tunnel syndrome, or is it a recurrence, or is it residual? So, or is it persistent carpal tunnel? All these conundrums are there. So to make our life easier, before intervention, or if there is any discrepancy in the clinical features, these tests do play a role. That is my view. And we follow Canterbury CTS scale. And the Canterbury CTS scale is a 7-point scale with the normal neurophysiology as 0. And so the digit 2 and digit 5 first test is normal, but only the sensitive test picks up abnormalities. Normal motor, that is very mild CTS. That is 1. And then even the digit 2 and digit 5, the first test we do, that picks up carpal tunnel, only sensory, but motors are normal. Then it is grade 2. But that sensory abnormality, if it affects only the velocity, but the amplitude is normal, that is 2. If the amplitude is also down and the distal motor latency is prolonged, then it goes to 3. Yeah. So 3 is moderate. And then if the sensory potential amplitude is completely lost, but the distal motor latency is more than 4.5 but less than 6.5, it is severe. If it is the distal motor latency is more than 6.5, but still we are able to record some CMAP over APB, which is more than 0.1 millivolt, then it is 5. And then there is absent CMAP and wasted muscle, and that is extremely severe CTS, which is 6. Okay, so why we need to do these things? So before doing those cases, I give you an indication about why we are doing this grading. Then we come to the cases. So those grades have meaning in it. With the 30,000, so when this graph was made, it was 10,000 tests, and everybody told the CTS symptom score, and there is a direct correlation, the linear correlation between the neurophysiological grading and the symptoms. And also there is a linear correlation between the Boston CTS grading and the Levine functional status subscale of that, with all the same scale. And now it has been reproduced with 30,000 patients. Still, it is correct. So these grading have direct relationship with the patient's symptoms and also the functional impairment score of CTS. The last one deviates because there is no pain, because it's end stage. They're completely wasted muscle and they don't have any positive symptom. That's why it is spuriously down, but everything else is very high. And when we compare the surgical improvement and how much people are getting a very effective relief from surgery, and how many patients are not getting worse or not coming back. So grade 3 is the maximum benefit. And the end stage also, they are not being benefited much. And the early one, they don't get much, but the maximum benefit comes from grade 3 of the Canterbury score. So that's why we normally follow grade 0, 1, 2 as only conservative treatment and symptom supportive care and splinting, and if at all, if they're gradually getting worse, injection, cortisone injection. Once they reach grade 3 and grade 4, that is the time to intervene surgically. And then after surgery, they need to improve at least to 2 grade down. So if they start with the 4, if they go to 2, they got the relief from the surgery. Even some people go further down, but not always. So, but if we leave it further later, then the benefit, it's too late. We missed the optimum time for surgery. So that is how we use these scores on a daily basis and liaise with the surgeons. So I show a couple of cases quickly and grade it. So these are all from physiology study, and 35-year-old female, very characteristic features of carpal tunnel, initially managed with the splinting and by the GP, and then because of fibromyalgia and other comorbid symptoms, they want to know whether it is indeed carpal tunnel before going to orthopedic surgeon, and this study was done. So on the right side, so digit 2, there is no potential at all, and yes, and digit 5, there is normal sensory potential amplitude. And on the left side, the digit 2 has a delayed peak latency when compared to digit 5. And digit 3 also has a small potential, but there is a trace-to-trace reproducibility. And I will say the potential is definitely there, but it is maybe because of technical difficulty or the patient's cooperation, there is no trace-to-trace variability, but it's diminished and delayed. Yeah. And that is what's shown in this. Peak latency is 3.5 in median, 1.97 in the ulnar. So that means more than 1 millisecond delay. So anything more than 2.97 is totally delayed. Okay, and the velocity also reflect that. On the other side, there is no sensory potential in the median, and ulnar is normal. So we don't need any sensitive test. And then they did the motor test. And the distal motor latency is, this is 2 milliseconds per division. So 6. So distal motor latency is 6, and it's 5 millivolt per division. So it is less than 2 to about 2 millivolt. So it's reduced CMAP. Yeah. And the forearm motor conduction velocity is normal. So those are all here. So distal motor latency is very severely delayed. CMAP amplitude is delayed. It's reduced, left to more than right. And there is a forearm motor conduction slowing of 43, and 49.9 is lower limit of the normal range. But on the left side, it is it's reduced. And ulnars are normal. But if you look at that, if you do stimulation of the recurrent motor branch below the carpal tunnel, you get a very good, more than twice the potential. So when you do a palm to muscle, palm to APB and wrist to APB, if the ratio is more than 1.2, it is due to conduction block. So that reduced CMAP and that delayed latency is due to conduction block at the carpal tunnel rather than an axonal pathology due to a severe carpal tunnel. If there is an axonal pathology, this much rise in the motor potential amplitude distal to the carpal tunnel will not be there. So indeed, the patient has a good prognosis in that way. So the patient has a bilateral severe carpal tunnel syndrome. This is will go to 5. So distal motor latency of about 6 and reduced CMAP, but still recordable. So very severe carpal tunnel, Canterbury scale 5, with a motor conduction block across the right carpal tunnel, which has a favorable prognosis. And this patient need surgical management straight away because it crosses 3. Indeed, it might have been referred earlier for management. Um, if something happens like this and in a non-dominant hand is more than dominant hand, definitely ultrasound is essential. But I would say ultrasound is essential anyway to know whether there is a structural pathology or the anatomy is deranged, to help the surgeon to know more than and to treat safely as well. And if there is no CMAP at all, what we can do is we can record, this is from wrist to lumbrical, which is 7.97 distal motor latency, very delayed. And still there is 0.1 microvolt millivolt response is recorded. But this is ulnar wrist to interosseous muscle, which has a normal distal motor latency. And that's all will be there in the motor action potential because a very thin muscle up to 1 millivolt, here it is 0.7. So, but this difference in the latency, which is very differentially affecting the median when compared to the ulnar, clearly localizes the lesion to distal median, and hence in the correct clinical scenario, it will support carpal tunnel syndrome. Yeah. So those are the cases I thought will be helpful. And these are the practices. And these are some of the splinting does help, but it's not completely. And most people will get worse, and then they will end up having injections and surgery anyway. And the steroid injection in 3-month success is more than surgery. If you do it in grade 2 or 3, that kind of stage, but once it reaches 3 or 4, it doesn't help. But in those cases of mild to moderate, mild cases, the short-term outcome is better than surgery, but long-term outcome is not that good, both of them. And also neurophysiological test will help us to understand whether the patient has cervical radiculopathy or some other pathology. It's not coming from the carpal tunnel or peripheral neuropathy, or we may get CADP in those patients sometimes. And also in selected patients, they are helpful to rule out and some genetic disposition like hereditary liability for pressure palsy. They will have CTS in non-symptomatic hand, and you will pick up ulnar nerve entrapment or subtle underlying demyelinating polyneuropathy. Then you may say that this carpal tunnel is not a idiopathic one, it is genetic one based on tuberculous neuropathy. In the children population, CTS is common in mucopolysaccharidosis 1. So there is a separate service in Greater Ormond Service, Greater Ormond Street, to screen those patients because enzyme replacement and stem cell treatment will not be useful for those. And these are children. So if they lose the APB, the functional impairment is more than somebody having a normal hand function. So apart from that, because myelination finishes at 3 years, all these values are normal, can be used for older children and adolescents. So this is my final slide for neurophysiological aspect before moving to a couple of slides for ultrasound. So by choosing the correct combination of neurophysiological test, we can give support for the carpal tunnel syndrome with high sensitivity and high specificity. And it provides a measure, a quantitative objective measure of severity, which correlates with other measures like clinical symptoms, functional impairment, and surgical outcome. And it has a prognostic value for surgery. And it is useful in determining what has happened after a failed treatment. And then it can help with ruling out alternative disorders and diagnose coexistent peripheral neurological disorders. And I'm not dwelling on this topic today because there are lots of papers regarding various parameters like cross-sectional area, notch shine, and flattening ratio, and bowing of the retinaculum, wrist to forearm ratio of the median nerve, all those things. But at the moment, this is where we are. This guideline is 2012, which is almost 10 years old, but still, till we get a very large number of class 1 evidence and class 2 evidence. At the moment, these two tests are complementary to each other. And American Academy of Electrodiagnostic Medicine advises ultrasound as accurate for diagnosis of CTS. And to rule out additional structural pathology, it does advise ultrasound, which has level B evidence. So in my perspective, what I want to say is we have lots of clinical scores, we have lots of electrodiagnostic scores, we have lots of ultrasound scores. Still, we are not having a surrogate marker of what a conduction block or Canterbury scale 3 or whatever severity scale you use, mild or moderate or severe, in terms of a sign or finding in ultrasound. We are not having a surrogate marker. They are having their own separate criteria. And there are papers with maybe 100 patients or 100 hands, 60 patients of comparing the parameters of electrodiagnostic finding and the ultrasound grading. But still, we don't have like thousands of cases with lots of controlled studies across the countries to validate these kind of related modalities to have a surrogate marker of each. But the need is now, it's ongoing, but nothing has published or accepted. A composite score involving your clinical symptoms, signs, electrodiagnostic finding, and ultrasound. If you're able to put a composite score, including all these things, that will be more robust in the diagnosis and the patient management. But we are not yet still reached that point. But that is something to do in future. Thank you for listening. I'm happy to take the questions later on.
It's a wonderful talk, Dr. Ati Ponusamy.
Thank you, sir.
Very, very nice, very elaborative and very useful lecture. And we'll take the questions at the end of the session and the chairpersons will coordinate. And we'll move on to Dr. Ganapathy Krishnan, Senior Consultant Plastic Surgeon at Apollo Hospital, Chennai, to deliver a talk on surgical approach to carpal tunnel syndrome. Dr. Ganapathy Krishnan. Can see your slides, sir.
Yes, I think that's a customary question everybody asks. Anyway, good evening to one and all. At the outset, let me thank Dr. Pazhani, whom I've known for the last almost 2 decades, a multi-faceted personality. Thank you, sir, and thanks to the Neurological Society for having called me in to give my perspective. Now, I'm possibly the odd man out in this audience of mostly, I think, neurologists. So anyway, let me try and give you what is my perspective or a surgical surgeon's view of managing a carpal tunnel syndrome. Now, yes, just a brief few slides will give you an overview. Carpal tunnel syndrome was initially coined by Sir James Paget as far as way back in 1854. And it was almost after about 8 decades that the first carpal tunnel release was performed. And then subsequently, of course, there have been advances, and of late, somewhere in the late 80s, the endoscopic carpal tunnel came into being by Dr. Kutso, and there have been certain finer refinements also in that. Now, I don't need to go into the anatomy, which has been possibly described. So this is just to explain to you that the median nerve is within this closed sort of facial compartment with bones on one side and the tight ligament on the other side, with at least about 9 tendons passing through along with it under the ligament. And this is where the compression tends to happen. Dr. Pazhani briefly mentioned about this, that there is something called as a resting pressure within the carpal tunnel, and it's usually around about 2.5 millimeters in normal patients. And any movement of the wrist, especially flexion or extension, can increase this to almost about 30 millimeters. And in carpal tunnel patients, you will find that it goes up to almost even 90 to 100 millimeters of mercury. And that's the basis of trying to perform the phalanx or the reverse phalanx test, wherein you give an acute pressure or an acute flexion or extension, and thereby increase the pressure and mimic the symptoms. The contraction of the flexors may also increase the resting pressure almost about 3 to 5 times. Sorry. And whenever the pressure goes to anywhere between 20 to 30 millimeters, there is a reduction in the epineural blood flow of the median nerve. And at pressures around about 30, you'll find that the axoplasmic transport also gets reduced. Now, most often the symptoms that these patients present are with numbness or night pains, which is very typical. And why does this particular symptom present, especially in nights? If you find that in the recumbent position, there is a redistribution of the fluid from the lower limbs onto the upper limbs, and thereby you will find there's a vasodilatation in the carpal tunnel. And also the lack of the muscle pump, especially at night when you're sleeping, you are not using your hands, so the muscle pump action is not there. So this also tends to increase the amount of blood and the pressures within the tunnel. And very often when people tend to sleep with their hands under their heads, it's either a little flexed or extended, which can again give rise to this pressure. And usually it's also noted that in late night and early mornings, there's a normal reduction in the body blood pressure. And this tends to decrease the perfusion pressure within the carpal tunnel. And very often you also find that patients tell you that they had the pain, they got up from the pain in the night, and by shaking the hands, they found that the pain was relieved. And this is because they tried to move out the fluid from these dilated vessels by moving or shaking their hands. Now, obviously, there are non-surgical options, as Dr. Ponsami was just saying, that in the early or the mild to moderate cases, it is invariably always a non-surgical option. Various modalities, of course, in the form of splinting, physiotherapy, or if it is work-related, you would possibly have to modify their work, especially if they are software professionals or somebody who uses vibratory tools, etc. Either a change of profession or possibly some amount of modification in their work environment. And drug-wise, of course, anti-inflammatory drugs, pregabalin, gabapentin would generally be tried, and sometimes even local steroid injections. Of course, I have no experience with local steroid. The only caution I would say is that it should be careful as to where you're injecting, because if you tend to inject it into the nerve by mistake, it could cause total irreversible nerve damage. And to reiterate that the non-surgical option has got obviously more role in the severe cases or when obviously you are noted some muscle wasting in the hand. So therefore, what are the indications for surgery? If the patient has got a mild to, or sorry, moderate to a severe case, as evidenced by a nerve conduction study, or if they have a failed conservative therapy, they might have possibly been on conservative therapy, say maybe 3 months, 6 months. But generally, if I say that over 6 months, if they have not had any relief, then maybe there is an indication to surgically release that carpal tunnel. And then, of course, if there is obvious motor weakness, as evidenced by a loss of abduction, which is there is a loss of the thenar muscle function. So if there is a motor weakness in the form of loss of abduction, or obviously you are seeing there is some wasting or atrophy of the thenar muscles, then again, I think surgery should be the option chosen. Now, what does normally one do in a surgical release? It's nothing but to cut the carpal ligament or the flexor metron, in other words. Thereby, you open up the carpal tunnel and relieve the pressure on the median nerve. So the surgical options are two. You either have an open carpal tunnel release or an endoscopic carpal tunnel. In the open, I would possibly be describing you the classical vertical incision method of release. There are also certain other smaller incisions which people use. And in the endoscopic, again, there are various techniques, but what I'm familiar and which I practice is the proximal single pore technique as described by Dr. John Edge. So in the classical open carpal, what do we do? It's basically a daycare procedure. It could be done under local anesthesia, but maybe you would have to avoid a tourniquet, because if you can be quick, of course, by finishing the surgery within 10 minutes or so, then maybe you could still use a tourniquet. Otherwise, they would have severe tourniquet pain. So in that situation, you may possibly have to use either a regional or a general anesthesia, in which case you can possibly definitely use a tourniquet. A vertical incision is made, which I will describe to you a little later. Once the skin is incised, the subcutaneous fat is also incised, and then you expose the carpal ligament. And this carpal ligament is then divided in its entirety, right from the distal to the proximal end. Completely, it has to be released, and the median nerve has to be visualized. And sometimes, if indicated, we also do a neurolysis, usually an extraneural or an intraneural neurolysis, because if you find that the nerve is very much compressed, or there is a narrowing or a smaller size, then we possibly will do a neurolysis. And once this is done, hemostasis is obtained, and the skin is closed in a single layer with a compression dressing and normal hand elevation. Switches are generally released or removed within about 10 days' time. Now, while making the incision, there is something that we use some landmarks. The most important is what is known as a Kaplan's cardinal line, which is a line which passes from the apex of the thumb web to just distal to the pisiform bone. And on this line, if you drop a vertical from the ulnar border of or medial border of the ring finger or mid finger, the point at which it meets this cardinal line is point A, is where the motor branch of the median nerve arises. And similarly, if you draw a vertical from the ulnar border of the ring finger, the point at which it meets this line, which is B, is the motor branch of the ulnar. So normally the incision is an extension of this line from the Kaplan line proximally, a little beyond or proximally beyond the wrist. That's a normal incision which is described. However, I tend to use a slightly different incision, which is a little medial to or radial to the classical described incision. This follows the thenar crease, and then at the wrist there is a small zigzag, which normally like to avoid a straight line scar across the wrist, and then onto the approximately onto the distal forearm of wrist. So what does, as I said, the open carpal tunnel release aim at? It aims to divide the carpal ligament in toto so that the nerve compression is totally relieved. So this is the incision, as I said, which I use, goes along the thenar crease, and then with a small zigzag at the wrist, it passes on to the distal forearm. And once the skin and subcutaneous tissue is incised, you expose the carpal ligament, and then the carpal ligament is divided. What you see, the edges here are the edges of the carpal ligament, and what you see right in the middle is here is the median nerve. And as Dr. Pazhani was saying, that sometimes if the compression is too much, you would find an hourglass deformity, which is very obviously seen here, that the nerve is a little thicker here, the nerve is a little thicker, whereas somewhere here, if you feel, you see that there is a typical hourglass deformity, which is seen here. So in those situations, we sometimes would also like to do a neurolysis. There have been people who have used smaller incisions compared to the classical incision, but I generally use the classical incision which I described. Whatever be the incision, the idea should be that you should be able to visualize the carpal ligament in toto and divide it in toto. So as long as you can achieve it through any type of incision, the result should be fine. Now coming to endoscopic carpal release. Now this is again a daycare procedure, but usually done under regional or general anesthesia so that you can use a tourniquet, because that's a little essential in this, but you could still do it under local. If you are quick at it, usually the procedure can be done in about, say, 5 minutes to 10 minutes maximum, in which case you could still use a local anesthesia with tourniquet. The incision, in compared to the classical, is just a 1 centimeter horizontal wrist raise incision. And once this is done, the scope is introduced through this into the carpal tunnel, and the carpal tunnel is visualized and it is divided in entirety. The small incision is then gently closed with sometimes a drain if required. Again, usually a compression dressing. The advantage here is that the patient can get back to work almost the very next day compared to the classical bigger incision. Here, the patient can get back to work from the very next day, and sutures, which are usually 1 or 2 at the most, are removed by about 7 days. So this is again a diagrammatic representation where, as I said, you make a small incision at the wrist crease. This is the scope. It basically looks like a gun with a lever there, which actually gives rise to a knife within the scope, which comes up or pops up. And here you actually go into the tunnel. The ligament is seen above, and then through this knife, which is called as an upcutting blade, you cut the ligament from inside outside. So in the classical open method, we expose the tendon, we expose the ligament and then cut it from, let's say, from outside to inside the tunnel, whereas in the endoscopic, you enter the tunnel and then cut it from inside. And that actually does not cause or can prevent any type of injury to the median nerve, because you are inside the tunnel and the cutting is from inside outwards. So that's the classical incision, and compared to the small skin incision as you see here in the wrist. And this is the equipment that we use for an endoscopic release. These are various dilators and synovial retractors. And then this is the actual release or the knife that we use, which I will be just showing you. I had my training formally at Virginia, wherein we worked on a lot of cadaveric hands. It's got a fairly small learning curve. It's not a big rocket science here, but once you get the feel of, looking at the monitor and possibly operating, I think it becomes quite easy. This is an animated video wherein, as I said, that's the gun that you use. A small incision is made at the wrist crease, and through that, the incision is somewhere here, and through that, this gun is passed. Here is the blade, which is on pressing the lever, it rises up. So you actually enter into the carpal tunnel. The ligament is above you, and then by pressing the lever, the knife goes up and you cut it from inside out. So that's how a ligament is cut. And then once the scope is removed, that small incision there is sutured with maybe 1 or 2 sutures. This is the actual video where, as I said, the scope is already into the tunnel. And what you see here is the upcutting knife. This is usually the distal end of the tunnel, as evidenced by the fat, which you can press and see. And then once what you see here is the ligament. Then you go in, and then from distal to proximal, you cut the ligament. Once you have cut it, you can go back and see for the completion of the division. This is the edge of the carpal ligament that you're seeing. Now, if you feel that a few more fibers here need to be cut, you can make maybe a second pass or sometimes even a third pass. But invariably, with 1 or 2 passes, you can totally cut the ligament. So this would have to be cut right from, as I said, distal to proximal. So comparing the two, I think both of them are quite comparable, the open or the endoscopic release. The only advantage is the lot smaller incision, as nowadays, everybody wants to have a small incision. They want to have a small surgery. So maybe following that, the incision can be small and the pain and the scar thickening, etc., are much smaller. And a lot of studies have been done where they have compared the endoscopic release as well as the open release, and they found really no big difference between the two groups with regard to secondary quantitative outcomes. And they have actually found that the grip strength and the scar tenderness, which is seen generally by about 12 weeks follow-up, is much better with an endoscopic carpal tunnel. So as I said, there have been various studies. Both techniques relieve the symptoms. There's no big difference in the risk of median nerve injury. And the endoscopic, however, has a superior grip strength and a lesser scar tenderness. Now, what are the limitations of surgical release? Now, you must understand that carpal tunnel release can only address a mechanical component of the pathology. Now, if there are other comorbids or other diseases or other conditions, which may be biochemical, endocrinal, hormonal, whatever, which actually are a cause for the carpal tunnel, that cannot be addressed by the surgical release. Most often, we find that the pain of relief and numbness are quite dramatic. In fact, the very next day or maybe the day after, when you first see the patient, they say that the so-called numbness or the tingling or the night pains are totally relieved. However, if there are intraneural pathology, that obviously again cannot be released by the carpal tunnel surgical release. However, as I said, we would try to sometimes do intraneural neurolysis. If that could help, it may help, but otherwise it's not guaranteed. And one thing which I tell my patients is that if there is a motor paralysis, as obviously seen by wasting of the thenars or loss of affection, that could never possibly get reversed because that's an actual nerve or a neural damage which has already happened. So most often what I tell them is that release would only prevent further damage or further deterioration of your condition. It could give you fairly good relief from the numbness and the pain, but in terms of the return of, say, sensations or the motor component returning normal is quite unlikely or would have take time. But if there is an obvious paralysis, I don't think that is going to be helped by a surgical release. Now, there are, as usual with any surgeries, there are complications, early complications and death complications. Usually it is a scar hypertrophy and pain, which are possibly some of the complications that we see with the open release. And the injury to the median nerve and recurrent touchwood till now in several hundreds of cases which you have done, we have never come across obvious damage to the median nerve, whether it is by open method or by endoscopic method. Similarly, injury to the superficial palmar arch, which again is a theoretical injury which can happen, but as I said, we have hardly come across any of them. So with this, I conclude the surgical aspect of managing a carpal tunnel syndrome. And if there are any questions, I'd be most happy to possibly take them and answer them. Thank you.
Thank you, Dr. Ganapathy Krishnan, for that wonderful lecture. And this endoscopic method, maybe that it is maybe new to people who don't do it very often. And it is some of my patients they have done, they've done extremely well. They are very happy with the small size scar also. So, and thank you very much for your lecture and opening lecture on management to carpal tunnel syndrome. Now I hand over the mic to the chairpersons for coordinating the questions to the speakers. Dr. Bishwa Kumar and Dr.
Dr. Vijayanand will take up the.
Yeah, thank you, sir. Hope we had a very wonderful lecture from Dr. Adi sir and Ganapathy sir. And anybody having question, either you can send by chat or you can unmute your mic and ask the questions. Yeah, I don't see anything. I have a, but
Dr. Megandan, Professor Megandan is there. Professor Banu. I think that the lectures are so good, I think, and they are so elaborate.
Yeah, yes, sir. Yes, sir. Yes, sir. Yeah, I have a small personal question to Dr. Adi, sir. Adi, sir, any role of MR neurogram, sir? I think you're.
Thank you for your comment and the question. So I don't have any experience. So there must be some role in it, but I have not done it or I have not seen it. I'm not able to comment on that. Yeah. So
because
yeah. So, it's not routinely done here. I have not seen in anybody doing that on a daily basis in case of clinical. There must be some PhD or somebody doing it somewhere, which I don't know. But on the clinical basis or as a service provision on a daily basis, I suppose there is a role MR neurogram is routinely now coming into practice, maybe in radiculopathies and other places. But the short answer to the question is I don't have any personal experience or view.
Yeah, because what happens here, no, sir, we actually get a reference from peripheral center where the sonologist is, I don't know what's his experience. That's what I just asked. If MRI can be compared easily, that's what I asked. Nothing, sir, nothing else. And
Vijayanand, there is a question from Dr. Sanjeev. Andrew,
yes,
will you take it?
Yes, sir. The doctor has asked, what's the frequency of carpal tunnel syndrome in pregnancy? Frequency of carpal tunnel syndrome in pregnancy. This question, Dr. Adi sir can answer.
Yeah, so it's quite frequent. Almost 20% of them do get it, depending upon other comorbid illness as well. Somebody having impaired glucose tolerance, and even the percentage is more. But most of them, the good news is after delivery, they will improve. So only supportive measures are the main management. And if after the delivery, if it continues to bother them after maybe a couple of months after that, then only that something needs to be done. So it varies. Suppose if you talk about a Mediterranean population, yeah, so the ethnicity also comes into play. So they have very high percentage actually. But in general, usually 20 to 30%, it's quite common during the end of the pregnancy, second and third trimester, and then they usually get better with after delivery.
Thank you, sir. Can I have a couple of questions? Vijayanand?
Yeah, I don't see questions from chat. Anybody can unmute their mic and ask directly. They what?
Dr. Vijayanand, can I ask a question?
Yeah. Yes, sir. Sure, sir. Sure.
A couple of questions. One is to Dr. Ponsami. How often do you see a false negative or a false positive nerve conduction study? Let's say you have a patient who has typical symptoms, possibly has a normal conduction, or vice versa.
Yeah, so both can happen. So the false positivity is 5%, false negativity is high, about 10%. So it can, in some selected studies, it can up to even 15%. So the false and negative study, what we think is just because there is no neurophysiological support for it, we can't say there is no carpal tunnel. So the report usually will say there is no neurophysiological support for carpal tunnel. Yeah. So, but then if the clinical presentation is classical of carpal tunnel, usually it is grade 0 of Canterbury scale. That means the symptoms are intermittent. Whenever there is, say, like your Phalen's test and during daily activities, when the nerve is put under pressure during whatever type of work they do, the way they do. So the nerve is compressed and there is an ischemic element affects the A delta fibers or C fibers. We don't fully understand it, causing these kind of symptoms because the nerve conduction studies are good in identifying large myelinated fibers. We are not able to assess A delta fibers and C fibers function during the nerve conduction studies. So, and also the reversible nature of the ischemic, once they release it, after some time, they will go away. So in those kind of state, if we do the testing, and if the underlying pathophysiology involves only that, then the nerve conductions will be normal. But once the focal demyelination happens or some axon loss happens, all those things. There's a compressive element which is ongoing, and then these activity exacerbates it. Then the nerve conduction studies will be able to pick up. So that's why we are not able to pick up in those pathophysiologies causing carpal tunnel syndrome. And the other way around is the neurophysiological testing will show median nerve compression at wrist, but there won't be any symptoms at all. Patient may not get any. So this we don't, so somebody say a referral might have been for a diabetic neuropathy, or so even for any neurological disorder, peripheral neurophysiology. And incidentally, if you talk to the patient, they won't have any symptom classical of carpal tunnel, but the electrophysiology will say, oh, there is a moderate carpal tunnel. So we don't say carpal tunnel in the report, because what we have evidence is median neuropathy at wrist. So there is evidence of median neuropathy at wrist neurophysiologically, but does it not equivalent to carpal tunnel? So this one, we don't know why that happens.
There is one more question. Dr. Ganapathy sir can take. Sir, one of the doctors has asked, what is the role of steroid injection in carpal tunnel syndrome? Exact administrative method and site.
As I told you at the outset, I have absolutely no experience in giving steroid injections into the carpal tunnel. And in fact, I was planning to ask the audience if any of you have it and how we give it. So I don't have any experience at all. Ideally, it has to be given into the carpal tunnel and not inadvertently into the nerve or into the tendon. So that's why it's a little difficult. That's why I'm a little apprehensive to even give these steroid injections. It's different when you want to give it for, let's say, a synovitis or something like that. But here, unless you possibly are doing it under, let's say, under ultrasound guidance or any other imaging, and you exactly give it into the tunnel, then maybe it would have its benefit. But then if by mistake you give it into the nerve or possibly even into a tendon, you can possibly totally destroy the nerve or the tendon. So I have absolutely no experience at all. And as I said, if
yeah. Okay, thank you, sir. If there are no more questions, any
Dr.
finishing?
I have one question, Dr. Vijay. Dr. Ati,
Yes, sir.
Who inject steroid in UK?
And the rheumatologist does. The rheumatologist does, yes. So there are landmarks, and we were with them, but there is a published guidelines where to put. The rheumatologist does it normally.
Do you do under ultrasound guidance?
Can do, but not necessary. There are very fixed landmarks. As Sir mentioned, Mr. Krishnan mentioned, the first thing is they just to see, as soon as before injecting, they will ask whether there is a median paresthesia. If it is there, then we are in the nerve. So like in some places, we withdraw and to see whether we are in the blood vessel before injecting. Here, as soon as the needle enters that point before injecting, if the patient says, "Oh, my symptoms are getting more," then they won't inject at all. Then they need ultrasound to know where the nerve is, to avoid the nerve. It could be some anomalous position, but routinely they inject without any ultrasound.
Many people here are worried actually because it's a very closed space, and the plastic surgeons who I refer, they are worried about injecting into the tendon also. They feel that if they injure the tendon, they should not be in the tendon, it should not be in the nerve, it should be in the empty space or the space available within the tunnel. That's why I asked how people.
It's a transient relief anyway. If some people are very against surgery, but that is not, surgery is always better.
But that's any more questions? It's a very wonderful evening today. All the seniors of neurology, senior consultant neurologist, and all my senior colleagues joined. And Dr. Ati Ponusamy has given a wonderful lecture. All the latest guidelines is very important, because I remember that the time I got training along with Dr. Ati, how much it evolved, the guidelines. And even though that the data is more or less same, the guidelines is a lot of evaluation. It's very useful lecture for us to update the latest information. And I thank Dr. Ganapathy Krishnan for this wonderful lecture on surgical approach to carpal tunnel syndrome. Because most of the time, what we see in our practice is, patient have complaints. We do nerve conduction, we diagnose, then whom to refer to for relief. Actually, here that there are good people to do surgical decompression. If you think clinically, it is very useful to the patient. And it is even though it looks very simple, it's very important topic, and it's very common compressive focal motor neuropathy we see in the practice. Thanks a lot again, and I want to especially thank our chairpersons, Dr. Bishop Kumar and Dr. Vijay Anand, for chairing this session and coordinating the question and answer session and very effectively. And we'll meet again, and it's a wonderful lecture. And anything you want to say, Dr. Bishop Kumar?
Thank you, Dr. Pazhani, for and the South Indian Neurological Academic Forum for giving me and Dr. Vijay Anand the opportunity to chair this session, which was very interesting indeed. The various aspects of carpal tunnel syndrome, the overview, the physiological studies, and the surgical treatment. It was all in all a great, useful session. Thank you for providing us with this opportunity. Thank you all for attending this. To all the participants, I owe my thanks.
We'll be recording this session, and maybe that we'll send to people who are not able to attend the meeting, because the main aim of these meetings is to propagate the knowledge, to reach the people. It's very, I learn a lot in every meeting. It's quite a learning meeting for myself. And thanks a lot again to all the seniors who attended the meeting, and special thanks to Dr. Ati Ponusamy and Dr. Ganapathy Krishnan. Thank you very much. We'll meet again.
Thank you, sir.
Thank you very much.
Sorry, I had some connectivity issues. I hope there were no questions after that. I'm sorry.
Everyone is appreciate your wonderful talk, sir.
Thank you.
Thank you.
Good night, brethren.
Good night.
Thank you, sir. Thank you very much, sir. Thank you, sir.